Hello, and welcome to another Debating Europe expert panel responding to your questions and comments on Europe. My name is Joe Ludovici. I'm the editor-in-chief of Debating Europe, and today we are asking how can the EU improve access and affordability of medicines? So I'm joined today by Jan Lecam, founder and chief executive of EU Audit's Rare Diseases Europe. Welcome, Jan.
Hello, Joe.
Hello, and I'm also joined by Nicoletta Lupi from the pharmaceutical company MSD, where she is MSD Italy's managing director. Welcome, Nicoletta.
Thank you. Hi to everyone.
So this panel is part of a series that Debating Europe is running on the future of healthcare called Healthcare Next. If you go to our website, debatingeurope.eu, you'll be able to see the other videos in this series. And the format of our panel discussions is pretty straightforward. We've been sent in a bunch of questions and comments from our readers, and the panel is going to have the opportunity to respond. So let's get straight into it. Let's start with the first question. And this is a video question which was sent in to us from Louis.
I would like to know how the European Union is going to make medicine available at quality standards equal to all the citizens of the European Union.
So this is a good question. It's sort of the question of the debate. I think it's a nice one to open things up with. Jan, if I can start with you, and then Nicoletta, I'll come to you. What would you say to Louis?
First, it needs to be a real objective of the EU, which means that we need to have a real political will to have that. It will not happen by magic or only by the aspiration of the citizens. And to me, that is what we're missing today, is that there is a lot of conversation, but I don't see the real political willingness, a strong expression of willingness from the European Commission, from the member states to have that. The European Parliament, yes, is certainly completely committed, and the European Committee, Economic Social Affairs. And the second is that we're facing very complex solutions here in terms of development of medicines, in terms of sustainability, in terms of access, etc. The solutions cannot be only developed by the European Commission or by one member state or one of the stakeholders. So the partnership between all stakeholders and open agreement and progress and compromise, I would say, or give and take from the different stakeholders is absolutely essential if we want to fix this question of more equitable access, but also more rapid access across Europe.
Okay, and Nicoletta, what would be your response to Louis?
My response is that access is not equal today. FPA data shows that the average time to availability for innovative treatments across Europe and the entire European Economic Area countries continue to be as long as 511 days. The average delay between the marketing authorization and patient access can vary by more than 7 times across Europe. Patients in Germany wait around 133 days to access new medicines, compared to patients in Romania that endure a wait of more than 899 days. As an industry, we are committing to doing our part. FPA member companies have committed to file for price and reimbursement in all EU countries as soon as possible and no later than 2 years from the Central European Marketing Authorization, provided local systems allow. And to creating a portal where marketing authorization holders can provide timely information regarding the timing and processes of pricing and reimbursement application in all the 27 countries. However, we also need commitment from the European and member states. We need to co-create a framework for equity-based tier pricing, and we need a collective commitment to information sharing around implementation of novel pricing and payment models. In countries like Spain or Italy, the access process requests additional time then for the adoption and purchase by the regional authorities. And furthermore, in Europe, we have heterogeneous access pathways also for vaccines. While vaccines must abide to the same rigorous licensing steps also applying to pharmaceuticals, Their market access pathway processes are completely different and vary per EU member state. So if I can conclude, in a recent publication co-authored by Vaccine Europe, a series of recommendations was made aimed at improving vaccine availability for Europe and beyond. The recommendations were made both at European and national level, targeting MITACs, HTA bodies, as well as vaccines manufacturers. Vaccine Europe is working closely with its members, national counterparts, and other stakeholders to implement some of them. We have developed a set of principles to enhance pathways for vaccine assessment and decision-making, focusing on timeliness, inclusiveness, consistency, and transparency. Similarly, we are in process of developing key principles for joint clinical HTA for vaccines, looking at current literature, best practices, and also, which is always very important, seeking experts' view in the field.
Perfect, thank you. Okay, so you've both sort of set out your kind of opening statements to this this question that we're going to be discussing today. It's interesting, I hear both of you sort of talking about political will and the importance of that, so that's interesting. Nicoletta, I also noticed that you opened talking about technological solutions, kind of technology as a potential way to address some of the disparities that you set out in your opening response. And this is actually the next question. This is from Julio. So let's play the question from Julio.
Hi, my name is Julio, and I would like to ask what would be the impact of the telemedicine and telehealth in general into the cost-related situation of future medicine.
Okay, if it's okay, let's start with Nicoletta. You mentioned kind of technology. So how optimistic are you about the possibility of telemedicine and telehealth having an impact on medicine costs?
I'm very optimistic about it, also because starting from the COVID experience, that I think has fully shown that we can move to telehealth faster, much faster than we thought. We all experienced consulting our doctor by phone or video when for years it was considered impossible to do. In the medicine space, one element to take into account is the electronic patient information leaflet. There are many advantages to electronic patient information leaflets. First, readability. Paper leaflets are complex to read. Sometimes think of how big they are. And digital leaflets have a much better layout, structure, and length. Then it's about safety, because paper delays the dissemination of updated product information, while digital leaflets are always up to date. And then simplicity. Multi-language paper leaflets made for complex packaging. This is not the case for digital leaflets. And at last, they're also environmental friendly. Digital leaflets don't require paper, packaging, or transporting. So this could be another piece of the digital transformation that could be definitely taken into account.
Thank you. And the same question to you, Jan, and maybe I'll just kind of preface it by saying there is some skepticism among our readers about how about the kind of the cost savings that can come from technology. Maybe some fear that during the pandemic we all got used to moving online, but that there is unequal access. If we're talking about equitable access, there's a risk of a kind of digital divide, but also that not everyone has the technological skills, and so there was some kind of concerns from our readers. So what do you think about telemedicine and telehealth?
There can be concerns. Let's start with the positive. What we have observed during the COVID, but it was already before, is that at least in a community of persons with rare diseases, so where you would consider that they want to have the direct contact with the doctors and to speak face to face, in fact, the use of telemedicine has really increased strongly, and they wish to continue. There is, in a survey that we did with 8,000 persons responding across Europe, over 90% of them express a high level of satisfaction of the service. And that works for the telemedicines with their hospital, but also with their doctors. What we see as interesting evolution is that you can work as a patient and have your meeting online from your work in a separate room. You don't have to take half a day off in order to go to the hospital. You can also bring in the pediatrician or your family doctor into the meeting with your hospital doctor, and that really is a big improvement. So we see another way of organizing the provision of care. So it's the economy is also there. We should not only look at what it costs in the system, but also enabling people to continue to work or improving the coordination of care with the doctors in the community. But I would say that looking at, in order to know if we are really saving money or not with that, we need to think also in terms of costing of the service. I'm not sure that it is normal to have consultations at the same price all the time, either with a doctor in the community or at the hospital. If it is a normal consultation, as you would have had at the hospital with your doctor, certainly. If it's just a follow-up consultation, which is another type, maybe that could be cheaper. And that's good for both, because then it goes more quickly and there is more consultations, and still there is a costing for that, which doesn't cost too much for society. There is also the use of the services. Is there an overuse, or is there a better use of the service? And that translates into economy. Then I would say that there is primary and secondary gain, economic gain. The first economic gain is that when you have a consultation online, if it's well organized, rather than to pay a taxi to go to the hospital or an ambulance and etc., maybe you're saving money into the system. But also the fact that you're having maybe the meeting more on time rather than later when there is a health issue, you're also improving the health outcomes. So so I would argue that there is more gain intuitively, but the numbers are not there. And if I can refer to a specific example, which are the European reference networks of rare diseases, which we have created over Europe, 24 networks covering different group of diseases, bringing together 2,000 highly specialized centers of expertise from hospital. And this part of the work is not yet done, to look at what's the cost of bringing doctors from different countries to work together into a clinical board, or having a consultation with a patient to discuss a diagnostic, to discuss a specific surgery intervention or whatever. And we need to do the costing of that and to agree on the cross-border payment of that in order to create a more fluid system and to have the expertise traveling to the patients rather than the patients always traveling to the provision of care. You're on mute, Joe.
There we go. I was just talking about the difficulties of technology and how people had struggled during the pandemic, and this is an illustration of that. But your last point about, the patients traveling, I mean, one of the interesting things about that is, of course, it could be across borders, which brings us to the next question, which is about prices, particularly across borders. And I'll just play this. They didn't give their name, but let's play the next video question.
Can the EU have a uniform price for medicines?
Jan, I'm going to stick with you to respond to this question, then we'll go to Nicoletta. So Jan, what would you say to this? So can the EU have a kind of uniform price for medicines? What are some of the, what are your thoughts on this?
Short answer is no. Longer answer is that I'm not even sure it's desirable. Do we wish to have one same price for all Europe for the same medicines? Will that be more equal? Will that provide more equity? No, certainly not. An equal price doesn't provide equity, right? Because that means that you will pay the same thing if you're a patient in Germany, in Romania, in Spain, or in Bulgaria. So we need, in fact, to have prices which are differentiated according to the capacity, economic capacity of the countries. And that's precisely what Nicoletta mentioned before, the tiers pricing. And that's something that we have promoted since more than 10 years, I think, with different reports and activities. And we published recently a statement with FPR, between EURODIS and FPR, which includes particularly tiers pricing as an area to promote. And this is where I go back to the political will, because now for that to happen, now the patients and the industry are saying, we're ready for that. We're absolutely ready for that. And this is how we propose to do it. 2 or 3 groups of member states with different, and the highest price of a group cannot be higher than the lowest price of the next group. But now we need the member states, with the support of the European Commission, to agree on doing it, to agree on the end of parallel import, and also of potentially the end of reference list price. So these elements are linked, and this is where the political will comes in. Now, my last comment on the uniform price is that it's one thing to speak about uniform price, another one to say, can we come together at the European level to discuss price and to discuss budget impact and to discuss payment models of medicines? And that we clearly say yes. And in fact, that's what we are strongly promoting. That can work for vaccine, as Nicoletta referred to, and it has worked in the context of COVID-19, but it works in the context of vaccine or of some treatments of neglected diseases at the global level with WHO. So it's not completely a new idea. It works also in Canada for vaccines, for instance, across Canada. It's not by provinces, but at the federated national level. So it could be the same in Europe. It could also apply in other areas where it is meaningful. So we're not saying it should be applied to everything, but for instance, if I take gene and cell therapies for very rare diseases, it's complete nonsense to discuss in 27 member states, because the people that don't even know what they're talking about. They don't know the disease, they don't know the technology, and there is so few patients that there is really no reason to have an hospital doing these procedures in every country. So it's only going to be in some countries. So that's really a reason where there is strong added value to come together at European level to discuss. But also there is a win for industry by, in this niche area, by having a faster access to market and predictability of revenue, and for patients to have a clearer pathway to the treatments, particularly through cross-border healthcare for this type of medicines.
Okay, so again, it comes back to this question of political will, which both of you have been emphasizing. Nicoletta, would you agree with Jan? Is there anything that you would add?
Yes, I do agree, maybe with one more specification related to vaccines, because it is true for COVID, it has been true for COVID-19 vaccines, because we were, and still today, unfortunately, are dealing with an emergency. Otherwise, it doesn't apply to vaccine either, because the question is really not whether you can have a uniform price for medicines, but I fully agree it's whether the EU should have a uniform price for medicines. The reality is that today, member states have a very different context when it comes to healthcare, and member states have different levels of wealth. Member states don't allocate the same budget to healthcare, and also healthcare priorities are different. Some diseases, for example, are more prevalent in some countries than in others. Would it really be fair for all these different contexts to pay the same price? In our experience, this will lead to a middle price, which will be interesting for some, but unaffordable for others. This is why we rather advocate, as I said before, and I'm glad that we're fully aligned on this, we really advocate for equity-based tiered pricing, so that to ensure that the price of innovative medicines and vaccines can vary between countries depending on their economic level and ability to pay, anchored in the principles of solidarity between member states and enshrined in the European treaties. To deliver an equity-based, fairer systems, again, requires the Commission and the member states to amend external reference pricing systems and undertake mechanisms to prevent the unintended consequences from internal trade.
Okay, we've got some, we're almost at the end now. We've got about 10 minutes left. I'd like to move on to some text questions. I don't think we'll get through all of these, but let's try and get through as many as we can. So the first one is sent in from Craven, who asks, are global rules around patents and generic drugs preventing equitable access to affordable medicines? Equitable, he uses instead of equal. Nice. Okay, Nicoletta, what would you say to Craven?
Well, to Craven, I would say, let's take a step back. What are patents? Sure, they are the intellectual property rights which are intended to protect an invention. So you cannot copy it. And for medicines, it means that whilst a patent is valid, a generic company cannot enter the market. But why do they exist? I'm Italian, and I can say that the Venetian Patent Statute established by the Republic of Venice was the first statutory patent system in Europe in the 15th century, a long time ago. Patents were put in place to encourage people to spend time, energy, and money on inventing useful things. Why bother spending so much time on a great invention if it's going to be copied by your neighbor the next day? In exchange for a patent, however, and the protection that comes with it, you need to disclose your invention, and hence, in the medicine field, you contribute to scientific knowledge. So, patents are there to foster inventions and transparency. A pretty good thing, I would say. Patents have set a term of 20 years, although for medicines they can be extended by an SPC simply because it takes about 10 to 15 years to develop a medicine. In total, the protection cannot exceed 15 years. So less than a patent for a new vacuum cleaner, for example. After the patent or SPC expires, which is, as I said, maximum 15 years, then generics can enter the market. And that's a pretty good deal, in my view.
Jan, would you agree? A pretty good deal?
Honestly, it's difficult to answer in 1 minute like that. There has been a lot of discussion, and before being involved with febrile disease, I was in the field of HIV, and we had all these debated at the international level also on patent. And I think there is the general rules, but there is also what we need to look at situations where maybe patent and intellectual property protection goes against the interest of an international common good in certain crisis situation. And I know it's still not an easy debate because investment has been done by some actors, and you don't want at the end to make decisions which are discouraging the investment for the next crisis. So you need to be very mindful about what's done. So that's why I would not answer more extensively on that, but just to say that I don't think that it's just one answer for all situations, that we also need to consider crisis situation or certain type of issues and how we manage both the protection of investment, as Nicoletta said, but also stimulation of competition. There is also plenty of examples in different industry which were ruled by protection, which now are completely opened in terms of open source, and it works very well. Mining is an area, for instance.
Interesting. Okay. Well, I'm glad you kind of drew this distinction between, public health crises, or, obviously we're still in a pandemic, and we will see what the winter brings. But the next question is from Jeff, who is asking us again a text question. He says the EU did a good job purchasing vaccines collectively during the pandemic. Could a similar approach be taken with medicines or with other medicines? Jan, what would you say to Jeff?
I think I already alluded to that. Yes, it worked. Now, it didn't work perfectly, but we learn how to do it maybe better the next time. And absolutely, for us, it's not that as a follow-up, we say it should be done in other areas. We are saying that since years already, but it shows life example that it is doable when there is the political will again. Because the treaty have not been changed, new regulation have not been voted. It's only the political will to answer to a specific situation. So we are absolutely calling for that kind of European approach, as I said, on gene and cell therapies, particularly for the rarest diseases, because this is where for us it's a no-brainer.
Okay, same question to you, Nicoletta. Would you agree? What would you say to Jeff?
I would say that for sure, the EU is already taking a similar approach to the one that was depicted before for vaccines, also in the context of the pandemic with the COVID therapeutics. So considering the different situation in an emergency, it has already been realized. So it's very important to consider if it's routine or if it's an emergency situation. The EU has certainly a strong role to play in this specific area. It makes sense. All member states are affected, all want access to the latest therapeutic to protect their population and ensure that their economy remains on track. There is a clear joint interest. One thing we have noticed as a company is that the joint purchasing systems are still complex and slow, but for sure, this will certainly improve over time. This does not mean, however, that it would make sense, as I said before, in all situations and for all products. In Europe, there is a principle of subsidiarity. Each action needs to be taken at the level that makes sense. Some diseases are more prevalent in some countries than others, so no need for joint procurement there. Some countries put a specific priority on specific disease areas for historical or cultural reasons, and this might be different from other countries. So let's not try to fit a one-size-fits-all where it does not make sense.
Okay, just Jan, please.
Yeah, just to follow up, to reiterate that, because Nicoletta mentioned it, is that I think we need to stop referring to the innovative system like we're doing in negotiating European level to address emergency situation, because it's like we're only learning from each crisis. So the question is not to do it when there is an emergency or to do it in routine. The question is to do it when it makes sense to do it at European level, because there is a strong added value. Emergency is one of the situations, but again, extreme rarity is another good reason to do it at European level. So we should really think where there is a good reason to do it at European level, rather than to think in terms of emergency, because that shapes then the thinking as we see today with the new agency on health threat, is that then the thinking is only around emergency. It's not only around emergency. Threats can be in other places than in emergency.
Yes, and in fact, this is a lovely link to the next question, indeed, because this question is from Jenny. I'll put it to you, Nicoletta, but she's sort of talking about, why can't we think in a more kind of long-term view and be less focused on kind of acute and kind of crisis healthcare prevention and treatment, and more about prevention. And so Jenny says, wouldn't greater public investment in prevention, early diagnosis and early intervention help improve public health and reduce the need for expensive curative medicines? And we did see during the pandemic, there were links in terms of healthcare outcomes with obesity and with other kind of chronic conditions. So what would you say to Jenny, Nicoletta? Shouldn't we be investing much more in public investment? I've heard this said a lot. It's not a new idea, but what's your kind of idea on your response to Jenny?
I couldn't agree more. I fully agree with Jenny. MSD, for instance, is a vaccine company, and prevention is one of our key area of work. Prevention in human health and in animal health, which is also very important. Prevention can reduce later interventions, and we have seen in many countries that national immunization plans, however, are underfunded or deprioritized. But the EU is also supporting better action in this field. Early diagnosis, early interventions are really critical elements, especially, for instance, in the oncology field, which again, MSD is actively engaged in.
Same question to you, Jan. And I think this is particularly an issue. We didn't talk about the kind of demographic trends and the idea that we're going to have an aging population and so on. But how would you respond to Jenny? And my question, I suppose, to add on to this is, I've been working in EU politics since 2008, and I've been hearing that we need greater public investment in prevention every year since I've been working in EU politics. So why haven't we seen this greater public investment?
The why, I'm not sure I can answer really, but the need, I can only agree with Jenny and Nicoletta on that. And I think all the advocates in that area are saying the same. We absolutely need more prevention, and prevention takes many forms. It takes the forms of education in terms of food, exercise, use of products, including drugs, etc. So there is a larger, and it's also health at work, and etc. So there is that large dimension, which is essential, which goes with plenty of regulation, which goes with education at school. I really think we should have education at school on health and nutrition. But it's also prevention in other senses, the immunization mentioned by Nicoletta, but also the follow-up by a family doctor, the follow-up by a dentist in order to have your prevention of deterioration. Let me take two examples to illustrate how this could generate gains and is not understood. I start by the micro, is rare diseases. We are advocating to have more newborn screening for rare diseases. Obviously, when there is a therapy which helps to stabilize or to cure, even then, we don't always obtain satisfaction of having newborn screening. But even in the absence of a curative treatment, because you have a better management of the disease and because you prevent the different clinical manifestations, or you delay them and you improve the quality of life, is already a fantastic outcome, including economic. This is just not understood. I take the second example, but it goes completely in parallel with aging. It is obvious that today we're treating the persons precisely not as persons, but as patients for hypertension, for that risk, for that cancer, for that diabetes. For what we need is a holistic approach. We need to have an approach of the person with all aspects of the disease, multidisciplinary and over time, and to start with a strategy of prevention early on. In the 20s, in the 30s, obviously more in the 40s and 50s, because it is by preventing each of the comorbidities that you're developing over your life that then you're delaying these expenses for society, but you're also improving the quality of health and a longer life with a quality of life. So what works for the people with the poorest or the strongest challenges of health, like in rare diseases, does apply very well also to aging. It's a strategy not only of prevention, but also of organization of healthcare and how you allocate your resources in order to improve your health outcomes over time. And that's the problem, I think, why there is no policy on prevention, is that we're always looking at 16 silos. France typically is doing that at the moment with President Macron, which fantastically promotes prevention, but prevention only speaking about primary prevention, not secondary, tertiary prevention, and not a strategy which is to improve health outcome, and I would say a longer life with a quality of life. That should be the objective to be measured. This is what counts.
I think that sounds very sensible. We have 2 more minutes, so there's one question left. I'm very happy we'll have finished all of the questions, but it doesn't leave you much time to answer. So I'll put it to you, Jan, and then to Nicoletta for the final word. So it's from Jim. He says, on medicines, we will probably always need large transnational, complex and profit-driven organizations, but we need to look critically at how they work and the context in which they work. And of course, we should not exclude other models in proper cases. Would you agree? Very difficult question for the final question, 1 minute, but what would you say to Jim?
It's a difficult one. I have no dogmatism and I'm not ready to run after utopia in that area. But we can see areas where non-for-profit production of medicines is essential. We see that with pharmacy of hospitals to continue to produce small quantities of products which are abandoned on purpose by the industry, and we can understand because there is no profitability for that product. It's an end of portfolio, but still the product is useful for few patients in certain therapeutic indication. Then maybe the society should take the role of saying, okay, we will produce it according to standards in a hospital pharmacy. That's done also in the context of pharmacy of the army in Italy, for instance, or in Denmark. And there is also other areas, if you think of the phages, for instance, to treat certain type of infections, particularly for severe burns or some severe bone infections, which cannot be protected by patent and where there is no much investment and are today in the academia, they could be taken by non-profit structure. So I think there is room for other models, but it's not the panacea. It's to address, again, where there is specific needs to be addressed.
Okay, and the final word to you, Nicoletta, one minute. How would you respond to Jim?
Well, I think I will go to the first part of Jean's questions related to the large transnational, complex and profit-driven organization. My company is a large transnational, complex and profit-driven organization. And I want to reassure Jean, of course, there is a public scrutiny on our company. And of course, other models should not be excluded. Any system and model are free to invest in medicine development. The fact of the matter is that because it takes between 10 and 15 years for a new successful, by the way, medicine to make it to market, and it costs a lot of money. And as an example, in 2019 and 2020, we invested $9.9 billion and $13.6 billion in R&D for new treatments and vaccines, respectively, from 2019 and 2020. That is equal to 28% of our revenues. It's true that there is a barrier that should be overcome. And over the past decade, we have invested $103 billion to develop new treatments and vaccines. In 2020, Apple invested 7% of its revenue in R&D. In other constructs, they've not been able to deliver so far. So this is the ratio between pharmaceutical and other sectors. This being said, we are not working in a vacuum. Public partners are also critical to medicine discovery. We work with academic institutions who are invested in basic research. We buy assets from startups that develop assets at an early stage, and this is good. Every part of the system has their own expertise, and it would be not fair, nor efficient to ask of one single actor to do absolutely everything. I believe as a system, we all contribute to an overarching good with our collaborations.
Okay, excellent. Well, we're out of time now, but we did manage to get through all of the questions from our readers, so I'm very happy about that. I want to thank both of my panelists today. Thank you, Jan and Nicoletta. Thank you very much. And thank you for watching. And if you do want to continue the debate, if you want to leave us a question or comment or check out future debates, you can visit our website, debatingeurope.eu. And don't forget to like and subscribe on YouTube and Facebook. Thank you to everyone, and goodbye.